Thank you, Mark. David didn't mention that this committee, these are party people. They like to have fun on these calls. So, these are my disclosures. I'm going to cover three issues, and really I've picked these three also because they illustrate the different ways that WFH have worked in this area. David's given an excellent overview of the work of the committee over the last 15 years. But the three examples, the WHO Essential Medicines List was an area where WFH led the effort on this area and engaged other stakeholders. In the area of orphan designation and market exclusivity, there was a European policy debate where WFH supported EHC and EHAD, and we took a joint position. And then in the long-standing paid plasma debate, WFH worked collaboratively with other patient organisations who use plasma-derived medicinal products. Well, the WHO Essential Medicines List, this was pioneered by WHO in 1977. It's revised every 2 years. They have a list of essential medicines. More than 130 countries use this list to develop their national essential medicines list. And the thing about this is it's no great advantage to have your product on the list, but it's a major disadvantage to have your product taken off the list. It sends a political signal to a health ministry that they can ignore Factor 8, Factor 9, DDAVP. So if it's removed, it's a really bad signal. And they have a list of core medicines and a list of complementary medicines. And plasma-derived Factor 8 and Factor 9 were on the essential medicines list prior to 2003. And incidentally, WFH found out that they were thinking about taking these off. We were alerted by HAEMOPHILIA, the Primary Immune Deficiency Patient Organisation, an early example of the need for collaboration among the patient groups. In 2003, the public health relevance and or efficacy and or safety of these products had been questioned, and their continued inclusion on the list were being reviewed. So WFH were alerted to this and swung into action. Desmopressin was added to the list in 1992 and deleted in 2003. And the WHO's Essential Medicines List parameters for rare diseases talks about a condition where there's a small number of affected people, therefore not a public health problem, little is known about the disease, difficulty with diagnosis, no effective treatment, and expertise for treatment not available. Well, the first two of those, while they do apply to haemophilia, clearly the others do not. Haemophilia is well characterised, easily diagnosed, there's effective treatment and a lot of expertise. And in the presentation, WHO pointed out that the safety and efficacy of plasma-derived coagulation factor concentrates was much greater than the alternatives such as plasma, fresh frozen plasma or cryoprecipitate, and also the association with healthy blood transfusion systems. And the outcome of that advocacy from WFH was that in 2005, Factor 8 and Factor 9 were retained on the essential medicines list, and that was politically very important. Desmopressin, as I said, was removed from the list, and in 2014-2015, WFH again worked to have this returned to the essential medicines list. I actually think it's more difficult to have something returned to the list once it's been removed than to originally have it retained. And this is an efficacious treatment that's affordable and safe. So WFH really managed a very good process where they brought together a coalition, including the coagulation factor concentrate manufacturers, other international societies, individual haematologists and treatment centres, trade groups, other charities and national blood services. And the outcome was that in 2015, desmopressin was added back onto the essential medicines list. In terms of orphan medicinal product regulations, this became a concern for us in Europe. The European orphan medicinal product regulations, which were promulgated in 2000, by 2014, over 1,200 therapies had orphan status in Europe, and 85 had been granted 10-year marketing exclusivity. Now, our concern from the haemophilia perspective was that market exclusivity could potentially be granted to the first extended half-life Factor 8 and the first extended half-life Factor 9 for 10 years in Europe, which would have meant a monopoly, which would have meant that the other extended half-life products would not come on the market. And that's certainly something we did not want to see happening. It might be reasonable to grant market exclusivity for a rare bleeding disorder or for a very novel product, but, you know, there are 40 licensed Factor 8 products and 20 licensed Factor 9 concentrates, so you certainly do not want marketing exclusivity. And, of course, if you have a monopoly, not only do you have lack of choice, but the cost tends to go way up. And their entire argument depends on the interpretation of similarity. We've spent many wonderful hours having a discussion on the meaning of the word similarity, while beside us angels danced on the head of a pin. They state that the products are similar if they have the same principal molecular structural features, which is certainly the case, they're factor VIII, and they act via the same mechanism of action. And in terms of mechanism of action, they talk about the same pharmacological target, the same pharmacodynamic effect. Now, EHC and WFH and EHAD all believe that products based on pegylation, Fc fusion and albumin fusion use different pharmacological targets. And in an editorial in Hemophilia, we set out the position where we talked about these products having demonstrably different protein modification or enhancement, and we talked about the danger of monopoly. And I think crucially, a joint letter was sent to the EMA by the EHC, EHAD and the WFH. It was also raised as a recommendation at that time at the European Directorate for the Quality of Medicines and Healthcare, who promulgate recommendations on haemophilia every couple of years. And the recommendation number 7 in 2014 stated that orphan drug designation for a factor concentrate should not be used to hinder the development, licensing and marketing of other products for the same condition which have demonstrably different protein modification or enhancement. This was very important because this was officially a recommendation from the European Directorate for the Quality of Medicines and Healthcare. What we actually managed by getting this accepted was effectively to have the Council of Europe criticising the EMA. So it was no surprise to me when the Council of Europe formally endorsed the recommendations that they removed this one. But it did get through the DQM process. The outcome was that the first extended half-life factor VIII licensed in Europe did not receive orphan designation or market exclusivity. The first 2 extended half-life factor IX products licensed in Europe did receive orphan designation, but crucially did not receive market exclusivity, and they're both now on the market in Europe. And I think a great outcome of this as well is EHC are now represented at all of the relevant meetings of the Committee for Orphan Medicinal Products. So we're in the room when these decisions are being made, and that's really important. Paid plasma. This is Groundhog Day. I don't know if you're familiar with the Bill Murray movie, Groundhog Day, where he wakes up in the morning. It's the same day over and over again. Now, I think all of us who've worked on this committee for the last 15 years feel that on this issue we are reliving Groundhog Day. The issue of paid plasma was linked to the WHO statement on self-sufficiency from 1975. And this is where ideology crosses out practicality. 80% of plasma-derived medicinal products globally are manufactured from the plasma of paid plasmapheresis donors. 61% for global supply from the USA, 12% from China, 7% from Germany. There's no prospect of an adequate supply of plasma-derived medicinal products being available from plasma of unpaid donors. We are all very much in favour of increasing the supply of recovered and sourced plasma from unpaid donors, absolutely. But you don't wipe out the major supply in this situation. The EMA statement, in fact, made it clear that plasma from paid donors is as safe as plasma from unpaid donors. But this issue is constantly promoted or raised by sectoral interests and based on lack of understanding of the difference between blood and plasma. And it's based on ideology and not on the needs of patients. So if you look, this is from the Market Research Bureau, if you look at, in 2014, there were 8.7 million litres of recovered plasma and 36 million litres of source plasma. So if you can imagine, if you said that the regulation should be that you remove all of this, then you're left with a dramatic problem. You're in a situation where 80% of your supply is gone. And over the last 10 years, the annual increase growth rate in the collection of source plasma has been 8.3% per annum, and of recovered plasma 0.7%. So I think you can see just from this graph that saying that you should ban paid plasma and only make plasma-derived medicinal products from the plasma of unpaid donors is just unrealistic. The CPMP position from the EMA in 2002 stated there was no evidence from clinical studies and pharmacovigilance that donor remuneration increases the risk of viral transmission via plasma-derived medicinal products, and they further stated the volume of plasma obtained from non-remunerated donors is quite insufficient to satisfy demand. So in this area, WFH, working with 7 other patient organisations, including EHC, IPOPI, Alpha-1, Guillain-Barré, ITP and hereditary angioedema, formed a Plasma Users Coalition in Europe, where we actually bring issues of mutual concern in relation to plasma-derived products and blood to the authorities. And we then started a consensus process where we decided it was time to bring all of the key players together in one room and start discussing these tricky issues where people have ideological divides and different opinions. And those meetings have been held annually since 2010. They have included PPTA, the Industry Association, IPFA, the Not-for-Profit Industry Association, European Blood Alliance, the International Society of Blood Transfusion, various national blood authorities, the International Federation of Blood Donor Organisations, European Plasma Collection Centres, the WHO, 29 patient organisations, including those in Europe, USA and Canada. And following this, the American patient organisations coalesced into A+, so you've got an American version now of Plus. And this process resulted in consensus statements being published in 2010, 11 and 12. And these were published in Vox Sanguinis in the first two cases and in the Journal Transfusion in the third case. And the consensus statement in 2011 talked about plasma products made from non-remunerated and remunerated donations are currently essential to meet global health needs, and that meeting the health needs of patients is the primary goal of blood establishments, and insufficient supply is a major safety risk to patients. The needs of patients should determine the optimal collection of blood and plasma. And I think this process was patient-driven, was driven by the patient organisations, and I think all the participants needed to be reminded that you collect blood and plasma not for its own sake. You collect blood and plasma to treat patients. So therefore your primary purpose must be the needs of patients. It also talked about, this basically are two statements in relation to mutual respect of each sector, the for-profit sector and the not-for-profit sector. These are short paragraphs. I can assure you it took 2 days to get agreement on every single word of these, but it was a very good process, and I believe it has moved people forward in their individual thinking. So the process we had was that each individual there had to agree to the consensus statement, and then if they agreed, it then went back to each of their respective organisations, who could either endorse the statement, not endorse it, or support it in principle with qualification. And it has been, I think, a very effective process, and it has led to at least people opening their minds to the other possibilities and the other points of view. Nobody has a monopoly on the truth in this area. So in terms of using these statements, Plus have used these statements in our meetings with DG Sanko and the various EU health commissioners. Plus and A Plus together have used these statements in our meetings with WHO and in expressing our concern with regard to the Rome Declaration. And the Rome Declaration was a declaration issued by the WHO talking about the need to basically ban any plasma-derived products made from paid donations. And interestingly, in that situation, you had Plus, A+, the industry sector PPTA, the not-for-profit industry sector IPFA, all expressing similar concerns to WHO on the Rome Declaration, what I would regard as an outbreak of consensus. And these are the responses from the four organisations. This is the first time in my memory that all of the patient organisations and the industry and the not-for-profit sector agreed on something like this. So that was a big step. So the paid plasma debate trundles on, endless fun, and this never ends. So they've had a lot of talk about this in Canada this year. Efforts to open centres for paid plasmapheresis have been stopped by provincial governments. Again, there's simplistic and outdated arguments being used to prevent collection of paid plasma, despite the fact that Canadians currently rely on products made from US paid plasma donors. And without plasma from paid donors, 70% of Canadian IVIG requirements would not be met. You've had nurses, unions, activists, and some people with haemophilia affected by viruses in the past opposed to this. The Canadian Haemophilia Society have been in favour of the paid plasma centres, and they're facing a very difficult advocacy and emotional argumentation about safety. And ironically, here you have the Canadian Haemophilia Society, who've done fantastic work supporting all of their members with HIV and hepatitis C in the past, almost being accused publicly by people of not caring about blood safety. It's ridiculous. And I think the tainted blood history in the past is being used to hinder progress, and the problem is that there are some people whose views have not changed, have not moved with the times since the tragic events of the 1980s. And these are just some of the pieces on this in the Canadian media. For-profit blood collection, a slippery slope, seeing red. On the right-hand side here, there's a letter from the Network of Rare Blood Disorders to the Canadian Minister for Health in relation to this, and on the right is a joint opinion piece which PLUS and A+, have drafted for the Toronto Globe and Mail last month. And again, I think this is a good example of an issue where the patient organisations, WFH, PLUS, A+, are coming together to help our colleagues in Canada on this issue. Thank you.